Clinical examination of cardiovascular system part 3 in the series for cardiology for medical students. In this section we will discuss auscultation of the cardiovascular system. Precordium is generally divided into 4 auscultatory areas, but other areas may be checked in specific situations. The common auscultatory areas correspond to the location at which corresponding valvular events are better heard. Aortic area is also called primary aortic area as there is a secondary aortic area along the left sternal edge. Primary aortic area is the second right intercostal space close to sternum. Pulmonary area is in the second left intercostal space close to sternum. Tricuspid area is lower left sternal edge medial to the apex beat, while the mitral area is at the apex beat, usually within the midclavicular line in the fifth left intercostal space. Other auscultatory areas can be used in specific situations, though not in routine clinical examination of all cases. Erb's area, third left intercostal space close to sternum, where the murmur of aortic regurgitation may be better heard. This region is also called secondary aortic area. Rogers area, fourth left intercostal space close to sternum, where the murmur of small ventricular septal defect, that is malady de Roger, is heard. In addition to these, certain regions are auscultated when specific lesions are suspected. Infraclavicular region, that is the first intercostal space, the murmur of patent ductus arteriosus may be better heard here. Interscapular, scapular and infrascapular regions. Collateral murmurs and the bruit of coarctation of aorta may be checked for in these regions. Carotids. Murmur of aortic stenosis radiates to the carotids. Selective radiation to right carotid indicates supravalvular aortic stenosis. Carotid bruit can occur in carotid stenosis due to atherosclerosis and predisposes to stroke. Bruit is the vascular counterpart of a murmur. Axilla. Murmur of mitral regurgitation radiates to the axilla and back. This is usually a feature seen in rheumatic mitral regurgitation with predominant involvement of the anterior mitral leaflet. In papillary muscle dysfunction, usually the posterior leaflet is involved and the mitral regurgitation murmur radiates medially to the base of the heart rather than to the axilla. Now we move on to the heart sounds. Two normally heard heart sounds are the first heart sound and second heart sound. Second heart sound has two components, aortic and pulmonary, A2 and P2. Normal A2 is heard in all auscultatory areas, while normal P2 is heard only in the pulmonary area. If P2 is heard at the apex, it can be considered as loud P2. Normal split of second heart sound closes in expiration and is audible only in inspiration. If it is audible both in inspiration and expiration, it is called wide split. If the split increases in expiration and closes in inspiration, it is paradoxical split. Wide fixed split is audible both in inspiration and an expiration without any change in the A2-P2 interval. Third and fourth heart sounds are usually heard in pathological conditions, but a third heart sound may be normal in children and in pregnancy. Similarly, an S4 may be commonly heard in the elderly. When S3 or S4 is associated with tachycardia, it is called a gallop rhythm, either S3 gallop or S4 gallop. S3 gallop is also known as protodiastolic gallop. S4 gallop is otherwise known as presystolic gallop. In tachycardia, S3 may fuse with S4 and produce a summation gallop. First heart sound is a high-pitched sound and is heard best with the diaphragm of the stethoscope. It is best heard at the cardiac apex. First heart sound is timed in relation to the carotid pulse as it occurs at the onset of systole. Interval between the first and second heart sounds constitutes the clinical systole, and that from second heart sound to the next first heart sound, the clinical diastole. The split of S1 is not audible usually, but may be heard in right bundle branch block and Epstein's anomaly of the tricuspid valve. In the latter condition, loud tricuspid component, that is T1, is known as sail sound, and it is due to the closure of the large anterior tricuspid leaflet. Second heart sound is also a high-pitched sound, better heard with the diaphragm of the stethoscope. Aortic component or A2 is loud in systemic hypertension and soft in aortic stenosis. P2 is loud in pulmonary hypertension and soft in pulmonary stenosis. Wide fixed split of S2 is a feature of atrial septal defect. Wide variable split may be heard in right bundle branch block due to delayed closure of the pulmonary valve. Paradoxical split can occur in left bundle branch block and aortic stenosis, but it is often difficult to appreciate in aortic stenosis due to the loud preceding murmur. Third heart sound is a low-pitched sound and hence better heard with the bell of the stethoscope. Left ventricular S3 is usually a feature of left ventricular failure and best heard at the apex. S3 in mitral regurgitation need not imply left ventricular failure, while an S3 in aortic regurgitation implies left ventricular failure. A right ventricular S3 may be heard medial to the apex beat in tricuspid area in right ventricular failure. Fourth heart sound occurs when there is a forceful atrial contraction and is common in the elderly with a stiff left ventricle. S4 is designated as an atrial sound, though it possibly originates in the ventricle. It can occur in acute ischemia of the myocardium when the relaxation of the left ventricle is impaired. Being a low-pitched sound, it is better heard with the bell of the stethoscope. Clicks may be divided into ejection and non-ejection clicks. The click of mitral valve prolapse is a non-ejection click. It is typically mid-systolic. Ejection clicks are heard in aortic and pulmonary stenosis. Vascular ejection clicks may be heard when the aorta or the pulmonary artery is dilated. There is one view that ejection clicks should be called ejection sounds. Ejection clicks are early systolic. Aortic ejection click does not move with respiration and hence it is non-phasic ejection click. Pulmonary ejection click moves away from first heart sound in expiration and is called as a phasic ejection click. Pulmonary ejection clicks become closer to the first heart sound as the severity of pulmonary stenosis increases. It is the only right-sided event which becomes more prominent in expiration. The phasic nature is due to changes in the pulmonary hangout interval. Hangout interval is the time delay for closure of the pulmonary valve after the crossover of pulmonary and right ventricular pressure tracings. Longer hangout interval of the pulmonary valve than the aortic valve is due to lower resistance of the pulmonary circulation. A phasic aortic ejection click may be heard in tetralogy of Fallot. It is a vascular ejection click due to the dilated aorta which receives blood from both ventricles. Opening snap is typically heard in mitral stenosis, though it may be there in tricuspid stenosis. It is seldom appreciated in tricuspid stenosis. Opening snap is a sharp, high-pitched sound heard better with the diaphragm of the stethoscope. It is heard best slightly medial to the apex rather than at the apex, where the murmur is usually loud and masks the opening snap sometimes. Opening snap occurs after the second heart sound and is earlier in severe mitral stenosis. Hence, S2-OS interval is inversely related to the severity of mitral stenosis. Opening snap disappears when the valve becomes non-pliable with severe calcification. The mid-diastolic murmur of mitral stenosis starts immediately after the opening snap. Tumor plop occurs soon after the second sound when a pedungulated atrial myxoma, right or left, pops into the tricuspid or mitral orifice in early diastole. It occurs when the diastolic movement of a tumor with a large stalk into the ventricle is abruptly stopped. Pericardial knock is an early diastolic sound heard in constrictive pericarditis. It is also called an early S3. The sudden rush of blood from the atria to the ventricles is halted soon by the thickened pericardium, which causes restraint for ventricular relaxation, leading to the pericardial knock. Pericardial rub is a superficial scratchy sound which is better heard with the person leaning forward. Intensity increases when the diaphragm is pressed on the chest wall. It persists on breath holding and is synchronous with the heartbeats, differentiating it from a pleural rub. Pericardial rub is triphasic with one phase each in systole, diastole and atrial systole. All phases may not be heard always, and it is well known to be evanescent. Now we move on to cardiac murmurs. Cardiac murmurs are initially classified into systolic, diastolic and continuous. They can be timed in relation to the carotid pulse. A systolic murmur starts with or after the first heart sound and ends at or before the second heart sound. Clinically, systole can be timed with the onset of the carotid pulse. Diastolic murmurs start with or after the second heart sound. By definition, a continuous murmur starts in systole, passes through the second heart sound into diastole. When the pressure gradient is high between the two chambers across which the murmur is generated, the murmur is high-pitched. Levine's grading of murmurs. The initial grading was based on the intensity of the murmur alone. Later, presence of thrill was added, with thrill being appreciated in murmurs of grade 4 and above. Conventionally, grading is considered for systolic murmurs. Grade 1, faint murmur audible only on auscultation in a quiet room by an expert. Grade 2, slight murmur. Grade 3, moderate intensity murmur. Grade 4, loud murmur. Grade 5, very loud murmur. Grade 6, loudest murmur. It is mentioned that grade 6 murmurs are audible with stethoscope close to the chest without actual contact. A murmur which extends throughout the systole is called pansystolic murmur, also known as hollow systolic murmur. Important pansystolic murmurs are those due to mitral and tricuspid regurgitation and that of a ventricular septal defect. Mid-systolic murmur starts a short period after the onset of systole. Typical mid-systolic murmur is that of mitral valve prolapse. Late systolic murmur could also be there in mitral valve prolapse. Ejection systolic murmurs of pulmonary and aortic stenosis start a short while after the onset of systole and is preceded by the ejection click. They are crescendo-decrescendo murmurs or diamond-shaped murmurs. The length of these murmurs are directly related to the severity of the stenosis. In ventricular septal defect, a loud murmur usually indicates a small defect with large pressure gradient across the defect. In a large ventricular septal defect, due to the large left-right shunt, pressure in the right ventricle increases. That is hyperdynamic pulmonary hypertension, so that pressure in the two ventricles are nearly equal. This results in a soft murmur. Early diastolic murmur starts with the second heart sound. Typical early diastolic murmurs are those of aortic regurgitation and pulmonary regurgitation due to pulmonary hypertension. That is the Graham-Steele murmur. They are decrescendo murmurs. In pulmonary regurgitation without pulmonary hypertension, the murmur starts a short while after the second heart sound. It's also known as a delayed diastolic murmur. In mitral and tricuspid stenosis, there is a mid-diastolic murmur. The mitral diastolic murmur heard in severe aortic regurgitation is known as Austin-Flynn murmur and could be either mid-diastolic or late diastolic, that is pre-systolic murmur. Now we move on to continuous murmurs. Continuous murmurs start in systole and continue through the second heart sound into a variable part of the diastole. Some of these murmurs are heard throughout the cardiac cycle. The classical continuous murmur is that of patent ductus arteriosus, known as Gibson's murmur. The region where this murmur is best heard below the left clavicle is known as Gibson's area. The murmur of patent ductus arteriosus peaks over the second heart sound. Another cause of continuous murmur is the rupture of sinus of valsalva into the right atrium or right ventricle. The continuous murmur of rupture of sinus of valsalva into right ventricle typically produces a murmur which peaks in diastole. This is because the tract which passes through the right ventricular muscle gets compressed during systole, reducing the intensity of murmur in systole and causes a diastolic augmentation of the murmur. Please subscribe to this channel for future updates. Thank you.